Hello, good morning, good afternoon, good night, wherever you're joining us. Thank you for being in our 11th lecture. Today, we will discuss the dilemma of systemic circulation in neonates, the evidence versus physiology, presented by Dr. Aimann Surak. Dr. Aimann Surak is a staff neonatologist for the Northern Alberta program at Stollery Children's Hospital and a clinical lecturer in pediatrics at the University of Alberta. His clinical and research interests are in neonatal hemodynamics, cardiovascular physiology, and improving the quality of image acquisition. For the panel discussion, we will be joined by Dr. Joseph Ting, who's an associate professor in the Division of Neonatal Perinatal Care at the University of Alberta and staff neonatologist at Stollery Children's Hospital. His research interests include neonatal infections and antimicrobial stewardship and neonatal hemodynamics and TNE. Also, we will be joined by Dr. Faith Su, who's a staff neonatologist at Mount Sinai Hospital and assistant professor at the University of Toronto. She has a clinical and academic interest in integrating cardiopulmonary physiology with gastrointestinal pathologies in preterm infants. And also we will be joined by Dr. Yogen Singh, who's a professor of pediatrics in the Division of Neonatology at the Loma Linda University School of Medicine and attending neonatologist at the Loma Linda University Children's Hospital. He has a special interest in neonatal and pediatric hemodynamics and advanced functional echocardiography imaging. Thank you so much.
Okay, I will just share my screen. Thank you, Daniel, for the nice introduction, and thank you for the NHRC for inviting me and Edmonton side basically to present about some of our work here to this amazing platform. Can you guys see my screen? Okay.
Perfect.
Okay, so today I'm going to talk about the systemic perfusion in neonates, a little bit of evidence and a little bit of physiology, and we'll see if these two go along together. Let me state some facts in the beginning. We know that the survival rate in babies and preterm babies improved significantly over the last decade or two. We know that the blood pressure is not a very reliable measure when we assess hemodynamics in general in preterm babies. The standard vital signs, they have limitations as what we will see soon in the next few slides. And the clinical assessment of the shock does not always correlate with the cardiac output that we measure routinely and often by echocardiography. Now, this is an example of one of our reports for a baby that we scanned from before. And as you see, one of the items on the impression was that there is a decreased systemic perfusion state. So let's see, what does that mean? The outlines of my talk is to review the components of the systemic perfusion, to review some of the ways to improve the systemic perfusion in neonates, because we should or we shouldn't. And hopefully at the end, we can put it together for better understanding of the systemic perfusion in neonates. Now, probably most of us have experienced this phase in our career. With more experience we have, our confidence sometimes goes down, especially when it comes to something like systemic perfusion in neonates. And this is probably related to the evidence that we have that it does not go along with physiology all the time. So sometimes we understand something and we expect some results from evidence, but we don't find it. Monitoring is very important, of course, right? The question is how often we should monitor. That's a difficult question to answer. The clinical practice in general tell us here when it comes to something like systemic perfusion is to not monitor that much actually and minimize the contact with the baby just from the developmental perspective. But sometimes we are encountered with evidence that tells us something completely different. Actually, more monitoring is more beneficial to achieve your goal. I just put an example of weight loss, for example. Now, these are the components of the systemic perfusions. There are too many. Could be clinical assessment, including the blood pressure, cap refill time, heart rate, perfusion index, and the urine output. We have some lab values, including the electrolytes, specifically the potassium and the lactate and the acid-base balance. We have some echo data and metrics that we rely on, including the SVC flow and the cardiac output. And more recently, people have been using NIRS specifically for cerebral NIRS. So let's start with talking about the blood pressure, and I'm just going to spend some time about the blood pressure because it's such an important parameter when it comes to systemic perfusion in neonate. We know that the blood pressure is simply a product of cardiac output and the SVR. So to maintain the blood pressure, in cases of decreased systemic vascular resistance, the cardiac output has to compensate and has to go up. And this is what we see on echo. It's hyperdynamic heart, as you can see, with a normal systolic function at least. And this is consistent with vasodilation, for example, septic shock. On the other hand, if the cardiac output is decreased, then the baby has to compensate with vasoconstriction and the SVR would go up. For example, this cardiogenic shock, very poor systolic function of the heart, and then this is consistent with vasoconstrictive physiology. Now, keep in mind that when the baby becomes hypotensive, it's too late actually. This is the relationship between the blood pressure and the cardiac output. And you can tell there is actually poor correlation between the blood pressure and the cardiac output. In ideal situation, you have a normal or high blood pressure and then normal or high cardiac output. That's fine. That's the normal state. Now, the blood pressure might be maintained despite the decrease in the cardiac output. And this is what we call the compensated phase of the shock, right? When the blood pressure becomes low in cases of decreased cardiac output, this is uncompensated shock. And the last scenario is the hyperdynamic circulation, when you have low blood pressure and decreased systemic vascular resistance, and of course, normal to high cardiac output. The blood pressure, I did mention that it's simply a product of cardiac output and the SVR, but things are much more complicated. It goes further than that to include many and multiple other factors that we need to look at for proper assessment of the blood pressure. And looking at the blood pressure alone as a marker of systemic perfusion is like basically looking at the tip of the iceberg. Blood pressure has limitations. We know that the blood pressure is a poor predictor of systemic flow. Nice study from Osborne et al. Revealing the relationship between the SVC flow and the mean blood pressure. And there is very poor correlation because you may have a situation where the SVC flow is low, but the blood pressure is maintained and normal. The other way around, you may have a normal SVC flow, but the blood pressure is low. So there is, in general, poor correlation between the blood pressure and the SVC flow. And we're using the SVC flow here as a marker of systemic perfusion in neonate. Similarly, when it comes to something like left ventricular output that we measure routinely on when we perform our scans, there is the same poor correlation. This is the ROC curve for the systolic blood pressure in figure A and pulse pressure in figure B, showing the sensitivity and specificity for these two parameters in relation to the cardiac output. And as you can tell, the sensitivity and specificity is probably around 70%. So it's not that high, actually. In general, blood pressure parameters correlate poorly with left ventricular output. What about the measurement technique? A lot of our babies get non-invasive or cuff blood pressure, basically, and we really have to pay attention to the technique that we're obtaining the blood pressure. I'm referring to the cuff width to the arm circumference, and the ratio should be really ideal so we can minimize the mean error of the measurement of the blood pressure. Do we know the normal values of the blood pressure? Well, we actually not really. Multiple studies tried to come up with normative data for the blood pressure in babies, term and preterm babies. And look at these studies. A lot of them were retrospective studies, so not ideal. Look at the number of infants included in these studies, not very high. And they've used different techniques, invasive and non-invasive, to measure the blood pressure. This is just to highlight the Supro blood pressure curves. This study was done back in 1995. It was prospective, and it involved over 600 babies. In our center, and also from my understanding, in most of the centers in North America, they rely on Supro's curves for normative values for blood pressure. Now, the traditional definition of normal blood pressure as the mean blood pressure is equal to the gestational age in weeks. This actually was an opinion or consensus came from 20 pediatricians. 2 of them were neonatologists. And it's possible actually that a simple blood pressure threshold that indicates the need for therapy does not exist. And we should rely more on other factors, including the clinical status and the systemic blood flow measurements. And this might be more informative. We know that the blood pressure is going to trend up regardless of what we do. So the blood pressure is going to improve with time in the first day, in the first 24 hours, and also in the first few days of life. Now, keep in mind that this was seen in multiple studies, and keep in mind that the rate of rise in the blood pressure does not actually change with antihypotensive therapy. So basically what I'm saying is, if you give inotropes or you don't give inotropes for the purpose of improving the blood pressure, it's going to improve in its own regardless. Since we don't know the normal values of the blood pressure, then technically we cannot define what is hypotension, right? There is currently no consensus regarding the actual definition of hypotension in neonates or when to act on it. This is from the CNN data from 2015, including all centers in Canada. And as you can see, the incidence of hypotension was very variable and very different between centers. And I can argue that the incidence of the blood pressure in these centers was not different. What was different, or the difference, was actually the definition of hypotension. Some centers, they had lower threshold to define hypotension and act on it with inotropes, for example, or fluids. And some other centers, on the other hand, they had higher threshold to define hypotension and to higher threshold to basically to act on it. And that's why we see this difference. What about the outcomes? We do what we do in the NICU for the purpose of having better outcomes later on. So is the blood pressure related to outcomes? Well, we know that mean blood pressure less than 30 for over an hour early on in life in preterm babies is associated actually with IVH. This is well known. But keep in mind that even babies who don't develop IVH later on, they started off with lower blood pressure. Looks like preterm babies will have low blood pressure in the beginning regardless. So if we improve the blood pressure, this outcome, specifically IVH and other outcomes, should improve, right? Well, actually, this was not the case when we looking at the literature. People have tried volume expansion to improve the blood pressure. And there was actually, in multiple systematic reviews, there was actually no difference in the outcome of death when it comes to the volume expansion. The same thing when it comes to IVH grade 2 to 4, there was no difference. People also tried inotropes to improve the blood pressure for the purpose of improving the outcomes. We know that dopamine, there is no question it's going to improve the value or the number of the blood pressure when compared to dobutamine. There is no question about that. But when it comes to outcomes, well, there is actually no difference. So PVL, IVH grade 3 to 4, there was no difference. The same for PVL, the same for mortality less than 28 days. This is the HIP trial by Eugene Dempsey. And as you know, they've randomized babies to receive dopamine versus placebo. And the primary outcome was survival without brain injury. And as you can see, for babies less than 26 weeks, or even more than 26 weeks, there was no difference in the primary outcomes. And if you look at the other secondary outcomes, mortality, BVL, NEC, PBD, etc., all of these outcomes were not different actually. So basically what we're saying, acting on the blood pressure and giving dopamine early on does not change outcome. Furthermore, in this CNN Canadian Neonatal Network analysis from 2015 showed that actually prescribing or administering inotropes early on for preterm babies could be harmful, is actually associated with worse outcomes, including death, ROB, IVH, and PVL, BBD, and NEC. So that's pretty scary, actually. The same thing for the steroids, and specifically the hydrocortisone that we use for the purpose of improving the blood pressure. There is actually no difference when it comes to death or mortality, IVH grade 3 or 4, and then PVL. So infants who are hypotensive based on the gestational age criteria, but otherwise clinically look well, and there is no evidence of poor perfusion or anything like that, probably they have the same outcome as normotensive babies. And probably this is why the term permissive hypotension in neonate came out to be a thing. I put here a question mark because we still don't know the definition of transitional circulation, transitional hypotension specifically. We don't know the etiology of it yet. We do have some theories. But I wonder whether a permissive hypotension in neonate is an entity versus it's a part of damage control resuscitation. And this is something that is used in adults with trauma, specifically hemorrhagic shocks. They actually do use permissive hypotension alongside with other things to stabilize their patients. But this is a part of the damage control rather than just a physiological entity. It's something very interesting to read and learn about. Now, let's move to the cap refill time, which is an important thing, and it's critical to assess, to measure when we assess any baby. But does it correlate with hemodynamics? Well, when it comes to stroke volume, we know that the cap refill time more than 6 seconds is associated with, is sensitive and specific for low or decreased stroke volume. But we're not going to wait until the cap refill time is 6 seconds or more. It's too prolonged and it's too late. When it comes to the cardiac output, it's similar to the stroke volume. In this study, they showed that cap refill time of almost 7 seconds is associated with decreased cardiac output less than 150. Again, we're not going to wait that long. It's too late. And there was no correlation with FS, heart rate, or blood pressure. Does it correlate with this with the SVC flow, which, as we mentioned before, it's probably the best available marker for systemic perfusion that we have currently. Similar to the blood pressure, there is a poor correlation with the SVC flow. So we do have situations where the SVC flow is decreased, but the cap refill time is less than 3 seconds, so it's normal. Keep in mind that the capillary refill time is influenced by a number of factors, including age, skin temperature, and the site and the duration of applied pressure. What about the heart rate? So we know that the cardiac output is simply a product of heart rate and stroke volume, right? So to maintain the cardiac output, the baby has to either increase the stroke volume or increase the heart rate. But I have to tell you that the neonates, especially preterm neonates, they cannot increase their stroke volume that much. And this is probably related to their Frank-Starling curve characteristics, as it's a flatter compared to term neonates or pediatric or adult heart. And for multiple reasons related to the preterm myocardium itself, and this was mentioned in multiple presentations from before. So technically for the neonate, especially preterm neonate, to improve or to increase the cardiac output has to compensate by increasing the heart rate. That's why tachycardia is a concerning sign in any NICU. The problem is there is a wide range for normal values, and the heart rate is influenced by a number of factors. And there is in multiple studies, there is no relationship between the heart rate and the systemic blood flow or blood pressure in several studies. What's more important than the heart rate is the heart rate variability. And I'm sure you've seen multiple studies talking about heart rate variability monitoring and how does it associate with some clinical situations, specifically sepsis. So heart rate variability and also heart rate trending is more important than just single assessment of the heart rate itself. Perfusion index. Now, we're just gonna have to pay a little bit more attention about the perfusion index, because it's actually a good parameter or metric to assess. It's that little number that we see on the monitor next to the saturation and the pulse. I'm not going to get into the technique of obtaining it, but you don't have to apply anything different. It's just a SAT probe that basically will calculate the ratio between the pulsatile and non-pulsatile flow, basically on where you're checking your SAT, and then we'll come up with this number. So for the last couple of years, I've been looking at this number more often, and it actually helps. So how was the perfusion index used in literature? We know in adults a decreased perfusion index less than 1.4 is associated actually with decreased peripheral perfusion in critically ill or ill adults. Right? That's in adults. What about neonates? The problem in neonates, if you stand at the bedside and watch the monitor for like 10 minutes or so, the perfusion index number or value goes up and down a lot. And it's very variable, especially in the first 10 or 20 minutes of life. So that's the difficulty in it. In general, it improves with time from the first day to the third day before it stabilizes on the 7th day. We do have actually some studies where they came up with some normative data, including the 50th, 5th, and 95th percentile for perfusion index. As a tool, it's reproducible actually. So there is a good reproducibility as a tool, which is a good thing. And there is also a good correlation with the SVC flow, which is different from the blood pressure or the cap refill time, right? And in this study, they found perfusion index to be correlated with the SVC flow in preterm infants with a negative predictive values of 98.6%, which is pretty good. So other clinical scenarios where perfusion index was used in literature. So they've related the perfusion index to the SNAP scoring and the illness severity basically in neonates. And we know that babies who score high on SNAP scores, they do have lower perfusion index compared to the babies who score low on the SNAP score. When it comes to something like choreo, perfusion index is actually good predictor of subclinical choreo, even early on or as early as 1 and 5 minutes. And you have here in this study some cutoff values of 1.74 at 1 minute and 2.18 at 5 minutes of age. Look at the sensitivity, specificity, and positive and negative predictive values. They're pretty good. When it comes to the most common thing that we encountered, so the hemodynamically significant BDA, similar to the blood pressure or the saturation pre and post ductally, the perfusion index can be measured pre and post ductally, and the more difference it is, the more consistent with hemodynamic significance of the PDA. And this is true as early as day of life, day 1 of life, and then day 3, and then so on day 7. This is interesting, and I don't know the physiological explanation for this, but high lactate level more than 4 associated with low perfusion index less than 0.5, which is pretty low, could be actually used as an early parameter to predict ROB and PBD. For anemia, it makes sense. For anemic babies, they have lower perfusion index. And then when you transfuse them, the perfusion index will improve. So that makes sense. Other markers of systemic perfusion include the renal function and the urine output, and then the potassium or hyperkalemia, which is related basically to decreased renal perfusion. It's something that we measure often, and it's very easy to measure and come up with the accurate urine output. And we assume that the urine output is a good indicator of cardiovascular function, right? But this assumption has several limitations. We know that the urine output is decreased in the first 12 to 24 hours anyway. And even if you have a normal urine output, you know, this could simply reflect the tubular dysfunction or immature function of the tubules in preterm babies. And then keep in mind the etiology or pathophysiology of the decreased systemic perfusion. It could be asphyxia, for example. So in context of asphyxia and decreased urine output, in context of asphyxia and HIE, sorry, the kidney may get a hit and the urine output will decrease. Even if when we do cooling, for example, you can see in this graph that the urine output is going to decrease you know, with decreasing temperature, and this is referring to therapeutic hypothermia in HIE cases. For hyperkalemia, again, when there is a decreased SVC flows, meaning decreased systemic perfusion, the kidneys will be less perfused, and then the potassium will accumulate, causing hyperkalemia. How about the acid-base balance and the lactate? So the physiology of this is that the decreased blood flow to any tissue will compromise the tissue perfusion, will cause the tissue to enter an anaerobic metabolic phase, and then this will lead to accumulation of lactate, basically. And when we measure it, it's high. However, for lactate to circulate from the tissue that is injured for whatever reason back to the peripheral circulation, there has to be enough circulation to do that, right? But if there is really decreased circulation and poor perfusion, then the lactate will not circulate basically back to the circulation. And then when we check it from a peripheral sample, it's going to be normal. On the other hand, the other reason for lactate to be normal is that the tissue, when it gets decreased blood flow, the oxygen extraction may increase actually, and to keep the lactate production and elimination in a stable condition, and this will prevent the tissue from entering the anaerobic metabolic phase, basically. However, we are still measuring the lactate, and the trend of clearing the lactate is very, very important. This is a serial measurement of serum lactate in newborn to identify newborns who are at higher risk for adverse outcomes. And this is these are over 200 measurements of the lactate in 75 ventilated babies between 23 and 40 weeks. And you can see babies who survived, actually, compared to the babies who did not survive, they had better clearance of the lactate in their circulation. We already mentioned this, that high lactate when associated with low perfusion index could be a predictor of ROP and BPD. What about the SVC flow? This is one of my favorite topics, and I'm a little bit disappointed, and I'm going to share with you why in a little bit. I love to measure SVC flow whenever we do a scan. So simply in adults, the cardiac output is distributed equally 50-50 between the lower and the upper body. The blood that's going to the upper body, 80% of it is going to go to the brain, and then subsequently it's going to come back to the heart through the SVC. In neonates, things are a little bit different. Instead of 80%, that ratio is only 25 to 30% that goes to the brain, as compared to the 80% in adults, right? Also, keep in mind that most of our babies, they do have PDA, and if it is hemodynamically significant, it's going to mess the whole flow distribution and the SVC flow as well. However, it's still measured in many other centers, and it actually, in multiple studies, they look at it as it's the best available tool to monitor the central perfusion in neonatal population, at least non-invasive tool, I should have said. The technique, what about the technique of the SVC flow? We actually have two main techniques in the TNE world. The first one, which is the classical or traditional technique, which was described by Martin Klockow and Nick Evans back in 2000. You visualize the SVC from modified long axis view, then you do measure the diameter over there using M mode, and then you Doppler it from the subcostal view, and then you come up with SVC flow. Now, there is intra-observer and inter-observer variability of 8.1 and 14% respectively. That's the traditional method. More recently, back in 2017, this study was led by Dr. Alan Gross. So they looked at the SVC from the short axis view. It's almost like a crab view. And as you can see, the SVC is not like a circle. So when you cut it, when you do cross section of the SVC, it has different shapes, and it varies during respiration, right? So they actually measure the area of the SVC flow, and then they Dopplered it from the modified suprasternal view. So basically from the aortic view here, you just tilt towards the SVC, and then you visualize it, and then you Doppler it, and then you come with SVC flow. So that's a little bit different. So they compared this new technique with a cardiac MRI, and then compared it, of course, with the traditional method. And actually, there is a better and stronger agreement with the cardiac MRI when it comes to the SVC flow. And then the intra-observer and inter-observer variability, both of them were improved, actually. But do we know the normal values of the SVC flow? Well, not really. In the traditional, so when it was described back in 2000, the cutoff of 41 cc per kilo per minute defined what's low, what's normal for the SVC flow. Multiple studies came up with different values, but the most common two cutoffs were the 41 and the 55. In general, there is a trend for the SVC flow to increase over time, especially in the first few days of life. But is it related to the neonatal morbidity? Do we know that? These are the morbidities described in the literature to be associated with decreased SVC flow. For IVH, we know that babies who developed severe IVH later on, they've started off with low SVC flow, specifically less than 30 cc per kilo per minute. Another study also more recently, they found that babies who had IVH, they've had a lower SVC flow early on. Probably this is more related to the hypoperfusion phase of the hypoperfusion-reperfusion injury, basically. When it comes to death, this is a prospective observational cohort for 40 very low birth weight infants, less than 1,500 grams. So the SVC flow, actually, the low SVC flow was associated with early neonatal death and or severe IVH. We talked about the hyperkalemia and decreased renal perfusion. And then more importantly, the long-term outcomes. We know in several studies, this is one of them, that the preterm babies who survived and they had poor outcomes, they had lower SVC flows compared to the babies who survived with no poor long-term outcomes. And babies who died and who didn't survive, they actually had the lowest SVC flow early on. So it could be used as a predictor for that. Other also developmental markers they've looked at I believe this is at 3 years of age, and it's actually low SVC flow. It's an important parameter to predict those outcomes. Now, since there was suspicion that low SVC flow is associated with some poor outcomes, then there were some interventions to improve the SVC flow. People have tried dobutamine and dopamine to improve the SVC flow. For example, in this is one of the first RCT to randomize babies to receive either dopamine and dobutamine at a high dose at 20 mics per kilo per minute to improve the SVC flow. And improve outcomes. Well, dobutamine compared to dopamine improved the SVC flow, but there was no difference observed in any of the clinical outcomes. But I just want you to pay attention to the dose they've used. It's at 20 mics per kilo per minute, which is pretty high, and I don't believe we get to this dose nowadays. People have tried melanoidin, and this is one of the studies where they've tried early prophylactic melanoidin versus placebo to prevent the low SVC flow in high-risk preterm infants. This is a double-blinded RCT. The primary outcome was maintenance of the SVC flow more than 45, but actually melanoidin did not do the trick. But again, it's a small study. This is a nested cohort study in infants less than 32 weeks, where they randomized babies to receive delayed cord clamping versus immediate cord clampings for the purpose of improving the SVC flow. And we know that delayed cord clamping improves actually the SVC flow compared to no delayed cord clamping. And this is why I was disappointed. We did recently a systematic review, which was published just last month, trying to figure out whether SVC flow is really related to neonatal morbidities and outcomes, but we found little evidence to suggest that the SVC flow in early neonatal period is a predictor of adverse clinical outcomes. Probably this is related to the technique of measuring the SVC flow. We don't have standardized definition of the cutoff to use for low SVC flow, which makes it difficult. Another thing about the SVC flow. I had the privilege to be an observer in Iowa last year, and I noted that they don't routinely measure SVC flow. So I asked why, and they said, here's why. It doesn't relate really with outcomes, and they've Adrian Bischoff from the Iowa group did this study to try to find whether there is a relation between the low SVC flow and the hemodynamically significant BDA, and they found poor correlation actually. Now, this is I just have to mention because low SVC flow is a marker of decreased systemic perfusion, and we rely on it actually to decide whether the BDA is hemodynamically significant or not. And I'm sure some of you use the ratio between the left ventricular output and the SVC flow, but actually this study found no relation. Cardiac output is another marker. Ideally, in an ideal situation, in the absence of atrial shunt or PDAs, the left ventricular output is going to represent the systemic blood flow, which will return to the right side, and then eventually it's going to go through the pulmonary vasculature back to the left side, and so on. But things are not ideal in our population because our population has the atrial communication and the PDA. So the left ventricular output is usually measured at the level of the aortic valve before the level of the PDA. So before the PDA originates from the aorta. And then some of that blood, or a lot of that blood, depending on how significant and big the PDA is going to go through the lung back to the left atrium. The left side will get dilated, and then eventually it's going to exacerbate the left ventricular output, which is measured at the aortic valve, as I mentioned. And this overestimate actually the systemic blood flow in cases of PDA. For atrial shunt, in this case, especially if the atrial shunt is large and hemodynamically significant, the right atrium in this case is going to receive blood from the LA as well as from the venous return. This will increase or optimize the right ventricular output, which represents the venous return as well as the atrial shunt. And the right ventricular output is measured usually at the pulmonary valve before the PDA joins the pulmonary artery. And we know the PDA, when it's large and associated with atrial shunt, especially large, more than 4 millimeter, it's going to cause right ventricular output to go up. So that confuses the whole picture in the QB and the QS as well. The technique, I'm not going to talk about it. I'm sure you guys are familiar with it, but I just want to mention about the insonation angle. This is a good insonation angle. Ideally, it should be 0, but if you can get it smaller than 20, that would be good. This is, for example, not a very good apical view. It's not apical technically because the apex is here and your probe is here. It's close by, and the insonation angle is not good. And this will cause your cardiac output not to be accurate. Do we know if the cardiac output is associated with long-term outcomes? Well, I'm just going to put a question mark here because we technically don't know. The last thing when assessing the systemic perfusion is the NIRS, basically. I know there was a talk from Purva Deshpande from Toronto group just 2 or 3 weeks ago, which was amazing about NIRS. I'm not going to get into the technique. Multiple studies tried to come up with reference values. In general, it increases after birth from 40 to 56% over the first couple of days of life it can go up to 78%, and then it settles and stabilizes between 3 to 6 weeks. Keep in mind that the NIRS reading is affected by multiple factors like skin color, the hair, the edema on the scalp, phototherapy, the skull shape and the head circumference, and some other factors as well. Is it related to hemodynamics? Well, the answer is Yes, because technically when we talk about the autoregulation curve and all factors and things which would affect the autoregulation curve would affect basically the cerebral blood flow and the NIRS reading. So blood pressure is one of them. So there is actually good relation or correlation with the blood pressure. So when the baby becomes hypotensive, the cerebral NIRS will drop down. Of course, if the autoregulation curve is not maintained, and then after the hypotension is resolved, the NIRS reading is going to improve. There is poor correlation with the cardiac output, as seen in multiple studies. When it comes to the SVC flow, there is actually a good correlation with the SVC flow. When it comes to hemodynamically significant BDA, there is also a good correlation with that. And with hemoglobin, it makes sense. If the baby is anemic, the NIRS reading is going to come down. And CO2 is extremely important. I underlined the CO2 and the ventilation because it's a very, very important marker that affects the how dilated or constricted the cerebral blood vessels and subsequently affecting the NIRS reading. Keep in mind that the low cerebral NIRS reading early on in life is actually not a good thing. Why is that? Because it's associated with morbidities and more mortality as well. So this is to show the cerebral NIRS reading in babies who developed IVH versus no IVH. And you can see that babies who had IVH later on, they started off with low cerebral NIRS reading, again, referring possibly to the hypoperfusion phase of the hypoperfusion-reperfusion theory. This is the ROC curve for cerebral NIRS for subjects with severe IVH or death at 7 to 10 minutes of life. And actually, it's a good predictor of that. So as early as 7 to 10 minutes of life. And the longer the baby remains or the longer the NIRS reading remains less than 40%, which is pretty low, the higher the probability of mortality and death. So low NIRS is not good, especially early on, especially if it's pretty low, less than 40%. So this is also for, I believe this is for the asphyxia. The cerebral, this is for long-term outcomes. This is just to show the relationship between NIRS reading early on and neurodevelopmental outcome at 3, 9, and 18 months, and then at 3 and 5 years. And we know that low cerebral NIRS early on is associated with some poor outcomes later on in life. Now, this is a really nice study done by Borva Deshpande and Toronto group, telling us that multimodal monitoring and using NIRS in babies is feasible, is safe, and well tolerated in extremely low birth gestation, especially in the first 72 hours. That's important because lots of time we get resistance from team members that they don't want to apply more and they don't want to do more for these fragile babies. This is one of the ECHO report from Edmonton that we did recently. And because we found decreased systemic flow state in this baby, in this particular baby, then we actually recommended, and we started recommending to use cerebral NIRS as an adjunct tool in the clinical assessment. So this was about the systemic perfusion. It has multiple and many components, as you can see. And you can add more, actually. You can add the cardiac MRI, which is more recent and becoming a little bit more popular. And by the way, yes, portable MRI machines are available. Non-invasive cardiac output is there as well. And you can add to the list. The list goes on. And that highlights the importance of integration of all of these hemodynamic metrics to have reasonable and accurate assessment at the bedside. And this is a randomized controlled trial that was done here in Edmonton. We finished recruiting, and we're in the process of statistical analysis. It's basically we randomized preterm babies less than 29 weeks to receive either multimodal monitoring, including NIRS, including TNEs, and of course lab and clinical assessments, compared to just standard care. And we did not find a difference in the primary outcome, which was the VVR scoring, but there is a tendency to have less BBDs in those babies who received the multimodal monitoring. It's important to look at the whole picture rather than looking at different pieces, right? And when we assess the systemic perfusion, it's really crucial to look at as many parameters as we could. And this is the importance of comprehensive hemodynamic consultation, which have been implemented in most of the centers, and many studies talked about hemodynamic consultations. I just want to mention here, sorry, I'm almost done, but I just want to mention here that the targeted neonatal echocardiography is not the same as the cardiac POCUS. This word is a little bit confusing for some people. Targeted might be perceived by some people that it is limited or restricted to something. For example, if you want to assess pulmonary hypertension, just look at the septal curvature and that's it. No, the word targeted refers to targeting neonatal pathophysiologies that are specific to neonates and preterm neonates. It doesn't mean it's limited or restricted to anything. It's still a comprehensive assessment. And just last month, this really nice study was published, and you can see the authors, very well-known figures and names in the neonatal hemodynamics, clarifying the differences between the comprehensive TNE assessment and the cardiac POCUS. You can go through that study. It's really nice to read. And but I just want to mention that cardiac POCUS is something very, very specific. It answers very specific questions. For example, is there a pericardial effusion? Yes or no? That's it. It's very specific thing. So hopefully at the end, with more experience we have, with a better assessment, with comprehensive assessment, our confidence will continue to improve. And hopefully the outcomes of our babies will improve as well. With this quote, I'm going to end my slides and I'm happy to take questions.
Thank you so much, Aimann. That was a really wonderful and comprehensive review of systemic perfusion. We have a few questions in the chat, and I just want to encourage everyone to add more questions to the chat as you would like. I will start out by asking you to comment a little bit more about the PDA. So there was a question about how much you really think the PDA is causative versus associated with IVH. And I know you didn't really concentrate on that very much in your talk, but let's hear your take on that.
I mean, that's thank you for this question. It's really a tough question to answer, but I believe, I think Purva a couple of weeks ago, she spoke a little bit about the transitional circulation. And the most acceptable theory or pathophysiology for IVH from the hemodynamic point of view, of course, because IVH is multifactorial, many factors impact that. But from the hemodynamic point of view, we talk about the hyperperfusion, reperfusion injury. So when the baby, like in the first, let's say 24 hours or early on, due to the increased or sudden increase in the afterload after removal of the placenta, there is a state of decreased perfusion because the left ventricle is faced with increased afterload. So there is an element of decreased cardiac output, especially if there is a PDA, which will remove also some of that blood. So that's the hypoperfusion phase. And then when the BDA becomes more hemodynamically significant and shunts more blood to the lung, that blood is going to come back to the left side, and it's going to further exacerbate the left ventricular output. And keep in mind that the brain is a pre-ductal organ, so it's going to receive too much blood at that point. And at that point, on day 2 or 3, the left ventricle had already, or hopefully, adapted to the increased afterload. So there is an increase in the cardiac output and the perfusion that the brain is exposed to. And that's probably the hypoperfusion, reperfusion theory. I hope I answered that question from the physiological point of view.
Well, that's a great explanation. Thank you. Also, there's a question about NIRS and the reflection of poor utilization of oxygen from the cerebral tissue, and that it's possibly a poor prognostic tool. What do you think about that?
So it's a poor prognostic tool, especially when it comes to the long-term outcomes. Like, it's easy to think about it for the short-term morbidities like PDA, anemia, and things like that. But when the cerebral NIRS is pretty low, especially very early on, especially as what we saw, like if it's less than 40%, which is pretty low, that reflects like almost asphyxia or like significant decreased peripheral significant decreased cerebral perfusion. And that's probably related to the this is the only way we can explain these long-term outcomes. But I still found it very interesting that you can predict long-term outcomes and death and mortality very early on, like in the first few hours of life, which is, you know, it's a pretty interesting, but I would say it's reflective of the significant decrease in the cerebral oxygenation. Also keep in mind the poor autoregulation, especially during that time. So, and it's not only the hemodynamics, there are many other factors, including the prematurity, including sepsis, including choreo, including many other factors. We also should pay a little bit more attention to our ventilation strategies, especially early on. The CO2 is probably the most important and critical factor that would affect the cerebral vasculature, whether they're constricted or vasoconstricted or dilated, affecting NIRS later on. So,
okay.
Yeah.
Thank you. I want to allow the rest of the panel members to join in, and there's certainly a little bit of chat going on about SVC flow, and you know, would you still use it at this point? You know, what do you make of the different techniques? And you know, are there other better echo measures that you would suggest instead?
Well, I mean, as I mentioned, like in multiple studies, the SVC flow is one of the best markers that we do have actually to assess the systemic perfusion. You know, it's easy, it's non-invasive. The problem is we don't know the normal values. When we measure it, it's not probably accurate, whether we use the traditional method versus the newer method, because like the SVC is not like a straw, it's not like a cylinder, right? Like it comes in different shapes and it changes with respiration. I would say the main problem with measuring the SVC flow is the technique of it. We don't have a perfect technique using the echo, of course, to come up with the SVC flow. And that's why probably the evidence does not show good correlation with outcomes or with other morbidities like PDA. That's why probably, and this was our explanation for why we didn't find relation with neonatal morbidities in our systematic review. Would I still use it? I would say we'll still measure it. It's a marker of systemic perfusion. What to do with it? You know, when you look at it on its own, of course, probably it's not that useful. Like any other marker, when you put it in context with all of the other markers and as many markers as we can get, probably it means something. If that makes sense.
Yeah, hi, Yogen here. Yeah, that makes sense. I mean, I agree. I think it is well reported that there is a better mark of the perfusion, but all studies show is a significant intra-observer variability as well. And I think at the moment, given we don't know the normal value, there's so much variability, and I don't use it in practice. In the research studies, yes, we can still use it. Again, we're trying to find out the best way to make sense of it really. In the clinical practice, probably if I had to use, I'll use the trending, just like the VTI. The problem with the SVC is, as you said, already showed beautifully, the diagram is a D-shaped. There's a massive change it's a big change in the size of the SVC. How accurate you do, even you're perpendicular to the SVC, then still during the cardiac cycle, with the respiratory cycle, there's a big change in the diameter. Do you measure only 1 or average over 5? More you measure, chances of the single 1 millimeter and 2 millimeter measurements, they just amplify. And those are the errors, risk of the errors goes high and high. So probably, I don't know, I think there was a big trend in early 2000 when those studies came out, but I think those studies are hard to replicate even on the, like in terms of the long-term outcomes. So I have to say, I probably disagree on this one. I don't use in the clinical practice at the moment. If I had to use the trending, I'll better on the VTI and the cardiac output VTI. As a part of the multimodal comprehensive TNE, yes, you can do it, but probably that'll be one of my least favorite markers compared to other markers in the TNE comprehensive assessment.
Yeah, no, fair enough. Thank you, Yogen, for this. And I completely agree with you about the reasons you mentioned. Yeah, I would just add that it's, to me, like I look at it as the BDA diameter. We know that the BDA diameter, when we measure it on 2D, on its own, it doesn't mean much probably, but when we look at the other markers of hemodynamic significance of the BDA, it probably means something. I know a lot of centers actually, they don't do SVC flow routinely. I mean, I still do it every now and then. We still train our fellows to do it, but
you really touched on it, I think, Aimann, with the sort of multi-parametric approach to any assessment, be it PDA, be it your cardiac output, a PPHN, that we, these are the typical things that we see, that there's just not a single parameter that gives us enough information.
Absolutely.
So I think you really touched on it. And I think that comprehensive assessment, and I mean, personally, we don't do it at Sinai because of the issues that's already been raised, but certainly that ability to have that global picture of the baby, and it's not just echo as well.
For sure.
It's also what the baby looks like. We add in years as a tool, just like you would for a blood gas and lactate. We never use a single blood pressure reading.
Absolutely.
So I think you've had a fantastic comprehensive approach, and I think being able to incorporate the things available to us and do it in a multimodal fashion is really key to give you a better picture of the baby.
Absolutely.
I can't agree anymore, really. And I mean, beautiful. That's such a nice, beautiful talk covering all the comprehensive assessment for the systemic perfusion. And I think those are all those tools are there, and some may be more relevant in one baby than others. I think it's important is to have all these tools in your kitty with a good clinical assessment, all these markers with the traditional markers and the TNE and the NERS, then make a very comprehensive assessment. Then look at the trending and make of those numbers. Do these numbers make sense in this particular baby? Numbers are off the chart, and baby is looking great, and the perfusion is good. Yeah. In those cases, you just look back where the mismatch is. I think that was a really nice talk that way, or the multimodal monitoring, I think we're definitely getting better in the right direction. And echocardiography, TNE, and the echocardiography assessment helps us immensely in that one, making those numbers and by clinical assessment, those numbers, putting together really. So I think we're in the right direction, making good progress.
I agree. Like I'm not going to repeat what have been said, but like model type of the assessment is the way to go, and no single echo parameter is going to be helpful. SVC measurement is I agree. Like the SVC measurement is particularly challenging in terms of the not to mention inter-observer, but even intra-observer difference.
Sure.
Particularly in the sense in those scenarios with very hyperinflated chest. It's really difficult to get those good quality of the images. So probably we need to rely on multiple parameters rather than single parameters to give some clues about the cerebral perfusion. So yeah, thank you. It's a good presentation to bring up those. You'll probably bring up more questions than give some definitive answers, but this is a good platform for us to generate more discussions.
And a question to everyone: when as our role when we do an hemodynamic consultation for systemic hemodynamic instability, what I have found is that we normally do less, we intervene less. We normally make the team to be more cautious with the fluids, and I love the example that Aimann gave, because normally the answer is you need to keep seeing the baby.
Absolutely.
So what was your experience in general? Because it might be misunderstood, and when we do hemodynamic consultation, we use a lot of drugs and we normally take them out.
So Daniel, I can start with that one. I completely agree. When it's like working in the blind, when you do not do the hemodynamic consultation, do not look on the comprehensive echo assessment, in that case, it's very hard for the clinician, for anyone, including us, including if you don't do echo. Am I dealing with a preload problem, or am I dealing with an afterload problem, or contractility problem here? So what you do really, keep on going up and up and up without understanding the impact. Just a classical example. If baby is not desaturating, your sets are very, very low, you keep on going the mean air pressure high, and that can lead to your preload problem. And to come over the low blood pressure and poor perfusion, systemic perfusion, you increase your inotropes and high. That's a very classical in the settings where we don't use echo. You use echocardiography. In that case, you use the good assessment, or most of the time we de-escalate, we come down on those measurements. We say, no, less, because then we got the power, we got this benefit of looking on all these markers where the problem is. If you're high MAP or high tachycardia leading to the very poor filling of the ventricles, we know we need to do something about it. And I think that's where the hemodynamic consultation power comes really more into the normalizing the physiology. And that's my experience. Without the comprehensive assessment, I think it's very hard. It is very hard to have a good picture of the cardiovascular physiology, really, blindly.
Yeah.
Great points. Oh, go ahead.
Oh no, I was just going to say I love that you mentioned Daniel and Yogen, that sometimes we get involved to remove things, like remove inotropes, yes, and do less, which is basically addressing the pathophysiology, yeah, with the tools that we have.
Yeah. A question was raised, which I absolutely love, so I want to be able to ask it. And it is, what do you think is the next best trial that should be done to help us learn how to manage neonatal outcomes better in terms of the hemodynamic markers?
Oh, that's a tough one. But it's a good one. But it's a good one. I can start by saying that we thought actually about something called the systemic flow scoring, right? I would say it's a difficult study to know, but if we can implement all of these markers and metrics that I mentioned, and we score them the same way we do scoring for PDA, and then we can try and we can link it with the outcomes, right? And I'm talking specifically about systemic circulation and perfusion. I still don't know how to do this study. Because it will involve a lot of monitoring, which is possible. It's not impossible, but that's the study I actually want to do prospectively. Yeah, and try to come up with definition with more accurate definition or score of or cutoff, let's say, for systemic circulation using all of these markers. I don't know if others have any other idea.
It's almost an impossible trial, I think. You know, from a sort of pragmatic standpoint, to have, you know, and you know, whatever tools that you decide, if it's echo or anything else, to actually not act upon, and actually have those results, you know, comparing a control group versus an intervention group. It's almost very impossible to plan that trial prospectively. Because, you know, from a day-to-day standpoint, I don't think many clinicians are going to be able to not intervene knowing some of the results that, you know, you do at the bedside. So it's a really tough one. I'm not sure if there's going to be a perfect answer for it, but certainly having whatever tool you decide to look at and basing it on clinically meaningful outcomes, I think would be a way to look at, you know, as an outcome measure, as opposed to just looking at, you know, diversifying from what normal data is.
I agree, Gina. I think these tools are there at the moment, and some of them obviously are not well tested in terms of the long-term, in the big trials and long-term studies. The biggest challenge is the recruitment and the conducting these trials, especially with the hemodynamics, really. Classical example, the HIP trial. Gene Dempsey did a fantastic job, but look on the numbers, it's really hard to recruit the babies, how long it takes to recruit these when the bias and when baby is very sick and sit tight without any, with only placebo or one drug, not using the other drugs. I think key for us as a community, as a hemodynamic community, is to join hands and at the multi-center involve more and more centers together, really, and put all these multi-model monitoring and then look on the outcome prospectively. Like, and if you had to combine in my, like, again, as both of them said, really, these are really difficult trials. This is one of the most difficult trials to do. But I think we had to put the multiple echocardiographic markers with the NIRS. And I think then look on the multi-center, see what like short-term, long-term outcomes are. But this will be a challenge. I can't deny that one. So.
Absolutely. I think, you know, I think those are all great comments, and absolutely, the HIP trial is exactly what I was thinking of as well. I mean, it makes so much sense to try to study it like that, but it's really hard.
Yeah, just to add to these difficulties is the dynamic nature of the hemodynamic pictures and the circulation for preterm babies, especially in the first few days of life. The hemodynamic phenotype changes from like hour to hour. So it's that's just to add to these challenges.
So that one, and also, again, some centers are fantastic. They've got a lot of reserves for the resources in terms of the manpower, in terms of the echocardiography as well. Some centers will have very limited number who are TNE trained people. And if you're under 24/7, like if you do any intervention based upon the like serial assessment, really, if you want a comprehensive echocardiographic TNE assessment, you've got to be 1 or 2 people in your center who can do. It will be 24/7, quite hard, quite challenging. And if you've got multi people, like good is a good team of people who can do those assessment around the clock, plus a good echocardiography machine as well. And then offline measurements, like what are offline measurements you do. Some of them may need those offline measurements as well. So it's a multi-factor, like the multi-model monitoring is a multi-factor challenges as well, not only technique, but also manpower and resources as well.
And I think that I think, again, a great point. And I think not only for research, but for clinical practice. And maybe the way to approach some of the studies and, sort of next steps might be thinking about how do you provide tools for when echo is not possible. So how do these other tools that are non-invasive and easily available for the general population, how do you correlate those tools with what you're finding on echo? And is there a way that we can give better guidance for when echo is not available?
And these are definitely really important studies, I think, to look at. We're sometimes very privileged in centers where we have that facility to do echo, and it's not always translatable, all over the world. But it may be, especially with, artificial intelligence coming and things like that, having these sort of taking even just bedside monitoring to use it correlating with some of the echo or other hemodynamic markers, maybe in the step forward to help inform people without these tools that we're lucky to have.
Very well said. Oh, sorry. Go ahead, Joseph.
No, it is like I completely agree. We are we some of us work in the center with a lot of the TN echo resources, but the problem is that some of the non-invasive monitoring they use even in the adults or the adult ICU, pediatric ICU, some of those tools may not be applicable or validated in those tiny babies, and we are facing an open PDA, which makes kind of distinguish between the LVO, RVO is sometimes challenging with those some of those existing tools. So I think more research still need to be done especially with those non-invasive kind of like technologies.
And just like when you mentioned the adults, really to validate these tools and various markers in the adults, you're talking about multiple thousands of cases in one big trial. And a lot of all the NICU trials, babies trial on the neonates we have got like 10s and 20s and 30s. That's our limitation at the moment. So even there's a good tool, and like we don't know even these markers. If you look at a bigger trial like 10,000 or multiple thousand, they may show that no, they're really good tools, but sometimes with the small numbers, it's very hard as well.
Great points. I think I'm going to take that moment to help us wrap up. I think this was an amazing session, and I want to thank Aimann for leading it and really sharing so much information with all of us. And thank you all for all your thoughtful comments and participation. And oh, go ahead, Daniel.
Thank you. So I'm just projecting the QR code for the session evaluation. So I'm just going to give some seconds for people to scan it. And again, thank you all. I don't know if you have any closing comments.
I'll say thank you so much for inviting me to this amazing platform. I always learn from it, and we'll continue to learn. Thank you so much.
I mean, you did a great job. There was a great talk and a great discussion. And thank you so much for inviting me and being part of it. Thank you so much.
Thank you.